Last thing, I think, yeah, we're going to talk about metastatic spinal cord compression. So, tumors, as we know, can metastasize and get everywhere. They can also go to the brain. They can cross the whatever things. They're super, I don't want to say superhero. They have superpower, okay? So, spinal cord compression can be resulted from those tumors compressing the spinal cord, or even the spinal cord itself is has a tumor, and this tumor is suppressing the healthy cells remnant. Okay, so this so what my teacher told me, what my doctor told me, sorry, that please don't sleep in the ER if they come to you and tell you that that there is a patient with cancer and suffering from severe back pain, because the first differential diagnosis you should think of is metastatic spinal cord compression, and it is a serious condition. You have to treat it very fast, because once you didn't treat it, that may cause spinal cord infarction, which means the cells in the spinal cord are going to die, and that might cause paralysis, and this is the last thing you want your patient to have. So please don't sleep, go and take it seriously, treat your patient. Let's go to the slide. Highest cumulative incidence seen in myeloma, 7.9, prostate, nasopharynx, and breast malignancy. Median survival following the first episode of MSCC was 2.9 months. Okay, so what is it trying to say here? That this is not very common, maybe. It happens with myeloma, like 7.9% of people with myeloma can develop this. Prostate cancer and nasopharynx, breast malignancies, okay. And if you let the patient untreated for 2 to 9 months, this is the survival rate. So very short survival rate. That's why you have to act very quickly. What are the causes? So, causes. Spinal cord compression can arise from a primary spinal tumor or any metastatic tumor with a tendency to spread to the vertebral column. So it's either a tumor in the spinal cord itself that is compressing the healthy cells, or it is another tumor rising, for example, from bone or from blood or from breast, and metastasize coming to the spine, to the vertebral column, and compressing this vertebral column, or even being involved inside the spinal cord. So what are the possible mechanism of metastasis include? So before going through the possible mechanism, we need to know what are the let's say the tools that cancer cell used in order to metastasize. So first of all, they can separate from the primary tumor. Okay, they separate from the primary tumor and go invade other tissues. Either invading other tissues like the surrounding tissues, or some of them they can we can call them hematogenous. They can go into the blood vessel and travel to distant places, or go to the lymphatic vessels and go to be obstructed at the lymph nodes, for example. Okay, so separation from the primary tumor. The first thing that these cells are not well adhered, tumor cells are not well adhered to each other, so they can be separated from each other. They go to the blood vessel, they go to surrounding tissue, and making secondary tumors there. So they will invade they will go through tissues around the initial lesion and penetration of their basement membrane and grow there. Or they can enter the blood vessel and survive there. So spread via blood vessel, called hematogenous spread. So now, what are the possible mechanism of metastasis include what? Hematogenous arterial seeding of bone. So now, what happened here? This is the most likely cause. What happened here? That those tumors travel through the blood vessel, okay? Here, for example, they're inside the blood vessel. They will go outside the blood vessel, and they will infect the bone, the body of the vertebra. So once infecting the body of the vertebra, they might cause the fracture, they might cause swelling of the spine, and this will in turn compress this spinal cord. So compressing this spinal cord will lead us to this thing that we told you. Another mechanism, shunting of abdominal venous flow to the epidural venous blocks by the vas vela minor. Okay, what does that mean? It means, let's look at this here. This is something they do it at a clinic to assess if there is compression in the spinal cord. They tell the patient, okay, this is what they call it. I don't know how to pronounce it, okay? They tell patient, sit down, can you bend and contract your abdomen muscle? This will cause compression on the spinal cord. If the compression was painful, then okay, there is a problem. There is problem in their spinal cord. Either it is oversensitive or there is something compressing this. Okay, so sometimes there is abdominal veins that maybe contain a tumor, or they are compressed, and they will compress the spinal cord in turn. Okay, this is one way the spinal cord can be compressed. So this will lead to high intrathecal pressure. Intrathecal means inside the spinal cord, the pressure is high. Tumor access epidural space via the neural foramen. Okay, so sometimes the tumor can find a way, find the door, and get inside and go in the compressor spinal cord directly, okay, through something called the neural foramen. We know that the vertebrae are like when we put them over each other, they will form those neural foramen. So those neural foramen will be the doors of this tumor to enter and compress the spinal cord. Okay, so what are the signs and symptoms? Now a patient came to me and I want to know what if he has this or not. First of all, back pain. If the patient comes to you, he has cancer and he's suffering from back pain, immediately think about spinal cord compression, okay? Sometimes he might lose the sense, the ability to sense, okay? You can assess that by touching the patient and see if he is not feeling the here or there. Sometimes there is motor changes because, the neural pathway is being disrupted by this tumor. So what else? Bladder and bowel dysfunction. We know that our bladder and our bowel, our intestine are controlled by those nerves, okay? So if the pathway was disrupted, we might have problems urinating, or we have like bowel dysfunction, okay? So those are some signs that may your patient may be present with. So what imaging modalities you need to do? You do MRI. MRI is the best, so preferred modality for initial evaluation of patients with suspected spinal cord compression. Provide excellent visualization of the thecal sac and surrounding soft tissue as well as bone. So we know that the spinal cord is surrounded by a thecal sac that contain cerebrospinal fluid. So we need to know the details. Is the tumor invading those sacs? Is it within the spinal cord, or it's just externally compressing this? So the MRI will help us know exactly what's happening here. So you can see this spinal cord is being compressed by those tumors. Okay, what else? You can, if you don't have MRI is not available, you do a CT scan, and it is timely efficient because we want to save time. We are in the ER, okay? You do CT scan. It will indicate if MRI isn't available or contraindicated. So sometimes MRI is contraindicated for certain patients, so CT could be. another modality. We have something called CD myelography. So this modality, actually, we use it maybe to compare between the result that we got from the MRI and the CT. So there is sometimes some locations maybe in the spinal cord that cannot be seen by the MRI. So CT myelography will help us to compare. So this modality is infrequently used, although it is comparable to MRI in terms of sensitivity and specificity. So it's very sensitive. It is specific, such like very close to MRI. Indications include laterally located lesions that are poorly visualized with MRI and radiosurgery treatment planning. So if you are planning to do a radiosurgery, you do CT myelography. If you are suspecting that the lesions are in the lateral side, so your MRI cannot indicate those things, you do CT myelography. So there is certain criteria to use this. What is the therapy you need to do? Give corticosteroids. Why? Because we want to reduce the edema. Do the surgery if it is indicated. So call the surgeon, tell him, is it okay? He will tell you if it is like very the tumor is very distributed and cannot be taken out. He will tell you, no, don't do it. Okay, so what to do after? You call the radiologist or the radiation team, okay, and you call them, is radiotherapy okay with this patient? So we want to reduce the size of the tumor, we want to reduce the source of the compression. So usually radiation therapy, we use it with soft tissue masses if the surgery is indicated, okay, is contradicted, sorry. What else? Something you should give. Palliative care, please. The patient is suffering from pain. Don't forget that, okay? We're treating the cause, but we need to treat a patient pain. Okay, by this we are done. Thank you for listening. I hope that you understood everything, and I hope that you don't take my talk literally, okay? If you found any mistake, please tell me that in the comment, because your colleagues need to know the right information. And if you are like have suspicions about it, go and look for that, search. Just don't depend on whatever people told you, even if they were very good, okay? So I did this because I'm very interested in this topic and I'm procrastinating. Okay, thank you for listening. Goodbye.